All right, we're going to get started. I'd like to thank everybody for coming out on a Wednesday evening for this presentation. This is a topic that I'm super, super passionate about. My name is David Coletta. I'm a physical therapist. I'm the founder and one of the owners of Excel Physical Therapy, which you are standing in right now or sitting in. I'm going to be presenting today with Dan Schiedmayer. Did I say your name correctly? And with Taylor Reicks. They're both physical therapists here at Excel Physical Therapy. We all three specialize in TMJ and associated disorders, which I'm going to describe what those associated disorders are. So I'm a certified orthopedic manual physical therapist, as well as Taylor and Dan are, as well as orthopedic clinical specialists. And I'm a fellow of the American Academy of Orthopedic Manual Therapy. We're very, very happy to have Dr. Booth, dentist, here tonight. Dr. Booth is a colleague of mine and friend of mine. And just a quick little story. When I came here to Bozeman, I moved from Denver about 25 years ago. And when I was working as a new therapist 28 years ago, in the clinic that I worked at, my boss came up to me and he said, just abruptly, "How would you like to stick your fingers in patients' mouths?" And I said, "I don't think that sounds real attractive, maybe not." And I went home and told my wife, and my wife said, "Maybe that was a mistake. You should go back and talk a little bit more about that." So went back and talked with Bob, and he said we had some therapists that were retiring that specialize in this area. It's a very specialized area for PTs, and we'd really love for you to learn from them so that you can take over from them when they leave. Which I did, but I only stuck around for 3 years before moving here to Bozeman. And I was super, super excited to meet Dr. Booth, who was very welcoming and opening to me to treat patients. And it's been a great relationship with him over the 24 years that I've been here. So tonight we're going to be talking about specialized physical therapy for TMD, temporomandibular dysfunction and associated disorders, as well as we're going to get a very nice dental perspective from Dr. Booth. So just to go over some learning objectives, we will learn the anatomy and function of the TMJ. We'll learn some of the postural effects on the TMJ and neck. We're going to learn the 3 basic categories of TMJ dysfunction. We're going to have Dr. Booth present on a specialty dentist perspective on treating TMJ dysfunction. An area that I'm super passionate about, I'm going to present on the neurological connection between the head, neck, and jaw and how those associated symptoms develop because of this connection. Hopefully that's not too detailed, but I think you'll appreciate it. We're going to look at the basic natural history of TMD. So how does it come on? Historically, how does this typically come on with patients? I'm going to give a specialty physical therapist approach to TMD. How do we evaluate and treat these patients? And then we're going to, at the end, talk about a few basic self-help interventions for TMD. And at the end, there'll be plenty of time for questions if anybody has some questions. So with that, I'm going to pass off to my associates here. Taylor.
All right, like you said, my name's Taylor Reicks. I've been at Excel for about 3 years now. I've been practicing for about 7 or 8 years. Just started getting into TMJ just the past few years, and David's been a great mentor as far as learning it. I'm just going to go over a brief little overview of just the anatomy and function of the TMJ, so you kind of have an understanding of that as we go into more detail later in the presentation. So on the first one here, my fancy little laser pointer, right here is the actual TMJ joint. And if you're feeling it on yourself and you just feel the little tragus of your ear, which is that little flappy area, you just go right in front of that and just slightly down. You just open your jaw a few times. You can feel something kind of poke into it. So that's this little condyle right here. That's what opens and closes as far as the jaw. And then this is zooming in and on over here. So we have the condyle right here. Then the actual joint space has this little thing called articular disc. So the disc there is basically a little cushion in between the 2 bones. And not a whole lot of blood flow, innervation, nerves, or anything inside of that. But behind of it is this little area called the retrodiscal tissue. And this is where all the blood flow and nerves sit. And this is what can become irritated and create some of our pain inside the joint itself. As far as muscles, there's quite a few more than what I'm going to go over. I'm just going to go over the 4 main ones that we really look at as far as treatment. So the first one is going to be the temporalis, which is the big one up here. Most of us think about our temples where we get a lot of our headaches. There is a very thin muscle there that kind of fans out along the skull. And then the muscle that you most likely know is the masseter. And this is the one that most of us associate with clenching as far as jaw pain, rubbing through here. That's probably the one that most people are most commonly aware of. And then there's two on the inside of the jaw that you're most likely not aware of. So this is the same mandible jaw section, but just cut out. So these muscles, there's technically two different muscles that sit inside the jaw. These are called the lateral and medial pterygoids. We'll kind of go over some of those, what they look like presentation-wise. But these are some of the intraoral ones that we would evaluate during a TMJ eval and see if they're tender or associated with some of the pain. And right here, I have a nifty little video to kind of show you what the joint looks like. So as you can see, what most people think of as a typical hinge joint, it just kind of opens and closes, but this one is more of a hinge sliding joint. So when it opens, it's going to slide a little bit as well. And so that's what we're looking at to see if you have any issues as far as rotation or sliding. So as you can see here, this is the condyle we were talking about, and that's the disc that sits on top of it. And this is one of the pterygoid muscles that we just talked about as well. And then when it goes to open, right there, it's going to hinge open and then slide forward. That's what's going to create our entire mouth opening. And so you could have an issue with the rotation part or the sliding part that would lead to you not getting a full open mouth. And then we'll go back to this video in a little bit to show you a few other things. And then just to kind of give a brief overview as far as posture and position and its influence on the TMJ joint. So a normal jaw resting position, which a lot of us do not do, is that when you're just at rest, like you guys are right now, your teeth should not be touching, you should not be clenching, and your tongue should be resting gently on the roof of your mouth behind your front top teeth. So for most of us, including myself, I'll end up being a clencher. I'm more of a mouth breather, so I usually have a little bit open more of a mouth. And that breathing influence has a huge impact as far as development with the TMJ joint. That's kind of outside the scope of the presentation today, but for a lot of us, including myself with like asthma and stuff like that, we end up being shallow chest breathers. We're all breathing up here. We're using a lot of our neck muscles to breathe. That happens, a lot of these get overactive and put a lot of pressure and tension through the joint itself. Where primarily what we should be doing is nose breathing and breathing with our stomach, with our diaphragm, slow and controlled, teeth aren't clenching. And then in addition, especially in our day and age, daily posture influence. So a lot of us that work remote, sit at the computer, sit and read, sit on our phones, we have that forward hunch position. When that happens, it puts a lot of pressure and a lot of tension through our front neck area, and it's going to pull down on our joint. And then it ends up causing a lot of issues through our neck too, which David and possibly Dan will go over too as far as the neck's influence on the TMJ. But there's a huge influence between both breathing and our daily posture that ends up leading to some of our issues. It's not always just, I'd say a majority of our patients that come in for TMJ issues have neck or headache issues as well of it. And it's very rarely an isolated TMJ issue unless there was a specific event. So you'll see in a little bit how those are still correlated. Then Dan will kind of go over some of the basic presentations. Oh, you want that? All right, cool. Yeah, there you go.
Yep. So I'm Dan. Similar to Taylor, I've been here for about 3 years, a couple months longer than him. And just like David was saying, instead of David's boss, he came up to us and said, "Hey, you guys want to learn how to stick people's mouths and treat them?" And we both found it was pretty cool. And so it's kind of led to us being here today. And David's been a great mentor for that. Now that we know a little bit about the anatomy and kind of the function of the joint, we're going to talk about what TMD or the temporomandibular dysfunction, how it kind of presents. Rough estimates kind of place it at about 30% of the population, of the adult population, has some form of dysfunction in their jaw joint. It could be as high as maybe even 11% in a pediatric population as well. And those sort of estimates are always just that, estimates. It could even be as high as some studies have found about 75% of the general population having signs of dysfunction, but not necessarily symptoms. So there are a lot of things that could be kind of moving abnormally. We as humans never really follow a strict rule per se. There's a lot of variability. So we don't necessarily always need intervention if we're not having symptoms, but at least kind of a third of the population has something worthwhile of investigating to kind of decide if this is going to be a problem that might develop, or especially if they're actively having symptoms, something that might need it as addressing. It typically affects women a little bit more than men. Some studies put it at about a 3-to-1 ratio, some as high as 9-to-1. I'm not going to necessarily conjecture as to why, but there are strong correlations with stress and other biopsychosocial factors that seem to indicate or maybe make an individual more inclined towards developing issues in their jaw joint. As physical therapists, we kind of classify TMD into 3 separate categories. First, there's one for referral from cervical structures. We'll talk a lot about today. Different muscles, the joints, the nerves that can all impact and present in the jaw. There are also disorders of the actual muscles of the TMJ that Taylor was mentioning earlier. Those can become dysfunctional and become very painful. We call that just kind of a general myalgia, which is a broad umbrella term for muscle pain. And then there are disorders of the actual joint, whether that be the disc or sort of an arthritis of the joint or degenerative disc joint disorder, DJD. However, with all presentations, there's more than likely going to be multiple factors, not just one of these. So, you know, most people are also going to have some neck issues, even if it's not the direct cause. You know, most people will probably have some sort of joint dysfunction, even if, you know, it's not necessarily the direct cause. So it's important to understand the multifaceted approach towards TMD management. Just like Taylor was pointing out, there's a pretty big overlap between mechanical neck pain and TMD. As I'm sure everybody's probably familiar with the infamous forward head posture, especially with screens and phones developing and becoming more and more part of our daily life. We tend to find ourselves here. And not only does that change the resting tension on the muscles of the neck, it's actually going to change the angles and the pulls on the jaw. It's going to kind of pull your jaw slightly inferior and posteriorly, opening it. And so your muscles, those masticatory muscles that kind of work to close the jaw and chew, have to have a little bit more tension to kind of maintain a proper resting position with those teeth slightly open, the tongue resting to the roof of the mouth. And with that increase in tension, there's kind of theories that maybe that is actually leading to some disc displacement, which we'll talk about in a second. Just as a little bit of a kind of a fun practice, if everybody kind of sits up nice, upright, good posture, and you kind of clench your teeth together, not super hard, but enough to kind of get your teeth together. Just kind of notice, where do your teeth touch? Is it kind of towards the front of the teeth? Is it more towards the back and the molars? Okay, just kind of open and close a couple times. And then I want you to really exaggerate a forward head posture, or maybe even bend down. Do you notice any change in where your teeth are closing? And then same thing, if we kind of come up and look up towards the ceiling, do you notice a change in where your teeth tend to touch and where they tend to close? Right, so that's kind of an exaggerated way to know, like, okay, based on your head and your neck position, that's going to affect the pulls on the on the jaw as well. And there's a whole bunch of things that we can really nerd out about that, but I think it's good enough lab demonstration for that. Not only are the joints and in the neck going to be affecting the jaw based on the muscle pulls, but the muscles themselves can also just refer to the joint. I'm sure everybody's probably heard of the idea of trigger points. They tend to have a referral pattern. So if people tend to get headaches, you know, sometimes their upper trap might be involved. You can kind of see that over there in the corner, following that nice, you know, curling around the head position. But your upper trap can also refer into the jaw. Same thing with some of your anterior neck muscles, like this big sternocleidomastoid, right? This guy that makes this shape right here. Sometimes if that gets really tight or dysfunctional, that can also refer into the jaw. So beyond just mechanically influencing the jaw, things can directly refer into the jaw, even in the absence of, you know, really bad posture or something like that. Moving beyond the neck and kind of its ability to refer into the jaw muscles themselves can develop trigger points. And you'll see, you know, looking at, say, like temporalis, right? That obviously refers into the jaw, sometimes even the teeth. There's that masseter. Sometimes trigger points can develop in there, referring to the jaw. So they'll have their own pain presentation. Basically, there are various reasons why these trigger points might form. We kind of blanket those into two separate categories. You can have an indirect trauma, which is basically an overuse sort of thing, maybe through parafunctions, things that your maybe jaw is not meant to do. So like grinding your teeth, clenching, a lot of bruxism, or biting your nails, biting the ends of your erasers. Over time, that could lead towards the overuse and the development of trigger points in the muscles. It could also happen due to direct trauma. Say somebody fell, hit their jaw, or they had an accident. Sometimes even after prolonged dental procedures, having their mouth open for a really long time, these muscles can become overly tight. On occasions, that can also lead to limiting your opening. They can become so tight they enter into a spasm. We call that a trismus, where particularly the lateral head of the pterygoid kind of holds on so much that it won't let you fully open, and it takes a really long time to kind of gradually work on relaxing those muscles again. And like we said earlier, it's all related closely with your posture, your alignment, and just your general jaw use. And we kind of said a little bit earlier, Taylor touched on like the resting position of your tongue. I always make a good point, like it's usually that n sound when you're about to say no, not, or never, the n, that tongue, tip of the tongue resting on the roof of your mouth is kind of the perfect position for your mouth at rest. So if you find that you're maybe a clencher, you find that you have a lot of like stress in your day, or you're developing some of these issues, I always tell people, catch yourself before you feel like you're maybe developing some of that tension, or if you notice it, tell yourself no, not never, rest there with your mouth closed, teeth slightly open. Moving on into the actual joint itself and the structure. So this kind of gets further brought down into three different categories and terms. There's just general joint pain called arthralgia, pretty nondescript. Usually they're pretty tender to the joint. It usually is a preclude or a precursor towards the development of one of these other ones, which can lead towards the disc being displaced. We'll check a video in a second, but like Taylor was saying, usually that disc should slide nicely down along that joint, but sometimes it can kind of get pulled anteriorly. They can find this on imaging. And when that happens, the joint has to kind of like skip up over onto the disc to really get its proper gliding and sliding motion. And if that happens, you'll probably hear a click when the joint kind of gets back on track. And then when you close back, it'll hop back off the disc and you'll hear another click. So we call that width reduction because it's kind of able to reduce the disc to get it back into the joint into place and align it. But over time, for a variety of reasons that we don't necessarily need to go into, basically that disc can become non-reducing, where the condyle doesn't really get up and over and onto it, and it become very limited or locked into a closed position, and that can also limit your opening. Over time, the jaw can remodel. Our bodies are very adaptable. So sometimes in these situations, sometimes in other situations, the joint itself and maybe even the discs can start to degrade. You know, if you think about arthritis in your knees, just like any other joint, your jaw is a joint and it has some cushions, and sometimes that cartilage and even those cushions can start to wear down. And so that's something that can also lead to some joint noises. Usually it's kind of more of a creaking or a groaning, less of a click with a click. But another thing to kind of be aware of, especially towards the later stages of more of these joint dysfunctions. Kind of going through a similar video just later on from what Taylor showed. So now we're going through the disc displacement. So you can see that disc itself, usually it's the lateral head is kind of the main culprit that everybody blames, tugging the superior head of the lateral pterygoid, tugging that disc forward, right? So now it's out of place. It doesn't have that nice initial spot to slide along with. So it kind of has to hop on at rest because it's not pushing on the disc. It's pushing on that retrodiscal tissue, which, as Taylor said, is pretty highly innervated. And that's usually the painful generator there. And that's when people start developing symptoms in this instance. And then to open, it's got to click, it's got to hop up over onto the disc, and then it functions usually normally. So you get past that little clicking point, and then it clicks on the way back as it resettles back into the socket, kind of on that painful area. People can have clicking without pain. It doesn't always progress to pain. So if you've had it for a while, it may not go away, and it may not also become a problem, but it could also be something to bring up or maybe even get checked out. And then eventually, if that disc becomes non-reducing and that disc just kind of gets pushed up, you'll see that that joint, that condyle, is failing to get up and over onto that. And so the jaw can't fully open because of the pain and because it's so limited there. And so it becomes locking. However, again, over time, that condyle may remodel, and so it may be able to get on up and over it, or the retrodiscal tissue may get stretched out. And that's something a lot of PTs, that's some of our skill set where we can help out and get that jaw functioning closer to a normal function that you may be used to or maybe need. And then here we're just kind of some nice images via cone beam CT scan showing some of those changes that can happen in the condyle. So up here we've got, you know, some normal looking, and then it's kind of progresses to more and more remodeling in the condyle of the mandible. And I think Dr. Booth might talk more about this, so I'm going to kind of skim over it. You'll see as it kind of slowly changes either through wear or maybe to kind of accommodate the changes in the disc. But it's always worth noting that, you know, with all imaging, it can be a good correlation, but not always a good causation. So there are people who have remodeled joints, if you will, that demonstrate bony deviations or like some what we'd call arthritis or maybe some remodeling in there, and they don't have any pain or they don't have any sort of clinical diagnosis that might be worth finding. So just the presence of that joint remodeling does not necessarily indicate a problem that needs addressing unless they also have clinical findings. And so for there, I think it'd be good to hand on to Dr. Booth to talk a little bit about what he does on the dental aspect of things.
Sure. You want ours? Well, David, thank you for the invitation. Nice to see friends and people we've worked with and seen before. I'm a dentist, and I have been a dentist for a long time, and I have a special interest in these kinds of problems. And they've done a wonderful job of presenting the anatomy and what the parts look like. David asked me to talk a little bit about the dental portion of TMD. And so I want to have everybody stand up again, get some blood flowing here. And I'm going to repeat one of the exercises that he talked about first, and talk about your head posture. So just look straight ahead and just close and touch your teeth together and just sense where they touch, wherever they are. Now I want you to tilt your head down. Does the fit of your teeth change a little bit? Tilt your head back. Does the fit of your teeth change? Yeah. How about if you tilt sideways a little bit? Does the fit of your teeth change? How about if you go into a rotation? Just rotate a little bit. Does the fit of your teeth change? So there is an association between posture and fit of the teeth. Could tooth position affect the head posture? That's an interesting question. If somebody wants to get their teeth to fit together, might they change their head posture a bit so that the teeth would fit together in that position? And that's the area that the physical therapists work with a lot. I'd like you just to put your fingers right in front of your jaw joint, and then, which is right in front of your ear, and then open your mouth. Can you feel that bump or that bone move? That's the lower jaw bone. Now take your little pinky finger and put it in your ear itself and have you open and close your mouth. Can you feel something move? That's the back end of the jaw joint. And so we have two jaw joints, one on each side. David has suggested that I set a timer to start, so let me do this. So I don't overrun, I'll subtract a minute here. Oops. And next slide, how do I change that?
We're just gonna arrow that way.
Okay. TMD, there's another, they talked about TM dysfunction, but there's also temporomandibular disorders. And you can have, it's temporomandibular disorders is a collection of musculoskeletal systems, problems with muscles, bones, joints, teeth, or nerves. And in this illustration, you can see the anatomy that's previously been presented, but notice that here's the ear canal. You've just all felt that. Now the jaw joint right in front of that. This is the temporal bone, and the lower jaw bone is called the mandible. So that's why it's called the temporomandibular joint, or TMJ. But notice these things. These are called teeth, and most people have teeth, or they want to have teeth, and that the lower teeth are hooked on the lower jaw and the upper teeth are hooked on the upper jaw. So how the teeth fit together influences how the jaw joint lines up. And things that happen in the jaw joint also influence how the teeth fit together. TMJ, the jaw joint dysfunction, could be limitations in motions, popping, clicking, pain in the joint, pain in the muscles, headaches, a referred pain, which has been talked about, or ear symptoms. Not everybody with TMJ problems have ear symptoms, and not all our ear symptoms are related to the jaw joint, but some are, and you just felt with your finger the close proximity. Trigger points have been referred to. This is an example where this temporalis muscle, the one on the side of your head, it's a very thin muscle and it covers a broad area, and it's a jaw positioning muscle. It's used to pull the jaw into a particular position. So if you're going to close your teeth together, your brain knows how you have to move your jaw to get your teeth to fit together and function comfortably. And so this muscle can have areas developing called trigger point areas where it's locally sore. You can push right there and it hurts there. And usually those trigger point areas will be small. They're about the size of a green pea. And that if you push there, it's locally tender there. But if that trigger point has been going on for quite some time, then you may have pain that is perceived in other places. And that's a hallmark of trigger points, is locally tender, but the perception of pain. Sometimes people will have tenderness in these muscles and they complain of a toothache. So they'll go to their dentist and they say, this tooth is killing me. And the dentist looks and says, I can't find anything wrong with the tooth. And so the patient goes away and they come back, doc, this tooth is killing me. You got to do something. Please do a root canal for me. So they do a root canal on a tooth here and the pain doesn't go away. And so they come back later and say, a bad root canal, redo it, please. And so you redo the root canal a second time and the pain doesn't go away. They come back and say, it's driving me nuts. You got to take the tooth out. So the person has the tooth extracted. Pain doesn't go away. Maybe that means that the source of the pain was not from the tooth. It could be that it was a source of the pain was in the muscle, but it's being perceived as in the tooth. And we see that on a daily basis as a dentist. You can also have neck muscles causing earaches or pain in the face or around the eyes. And those are pain referral patterns that has been talked about earlier. This is 3D imaging. It's a cone beam CT scan, and we use this in our office to treat patients all the time. I just am amazed at that kind of image that we can see, and we can actually on the computer spin it around and turn it upside down and look at all different directions. You can also, in CT imaging, take a slice out of a particular area, like a slice out of a loaf of bread, and look at that data and exclude the other data, and you can move those slices around in any way you want. And I'll show you a couple of images of that. The thought of just having that kind of imaging in a dental office in Bozeman, Montana is truly amazing. Disc displacements have been talked about. But if we look, here's the ear canal in this normal joint, and this is the anterior slope of the temporal bone. And here's the mandible, the lower jawbone, and there's the cartilage disc that's been illustrated. Muscles hook on that. And you'll see that that bone fits about in the middle of the socket. And in opening, the jaw moves forward, the little cartilage disc slides forward, as has been illustrated already, and then it goes back together again. And that's a normal functioning. This cartilage disc is different than other cartilage like you have in your knee. That in your knee or other joints is hyaline cartilage, and this is a fibrocartilage. And so it behaves a little differently. You may have had injections into your knee with steroids for various problems to help with that, but cortisone injections in jaw joints tends to be harmful to the fibrocartilage. There is one other joint that has a similar sliding cartilage disc like that, the sternoclavicular joint, but that's the only other one in the body that is similar to that. Now, in this situation, here's the ear canal, here's the base of the skull, the lower jaw, and you see that that bone is not lined up in the middle, it's actually pushed to the back of the joint. And so when the jaw gets pushed back in the joint, then the little cartilage disc gets pushed forward. And so earlier it was illustrated that muscle pull on can displace the disc, but you can also have a physical migrating of that disc forward because of the pushing of the jaw backwards. How could the jaw get pushed backwards? Remember earlier I showed you how the teeth fit together influences how the jaw lines up. And so sometimes things in the dental world are influencing how the joint itself functions. Now, this is the same illustration you saw earlier of the disc of the jaw popping over that posterior border of the disc and assuming a normal position. And there is a percentage of people in this audience who have popping and click in their jaw. Not everybody develops symptoms from that, but sometimes it is from an acute trauma when you fell when you were 5 years old or 9 years old, or you had a sled wreck, or you had a knuckle sandwich or a monkey bar accident. But that would be a macro trauma. Micro traumas can be something small that's occurring repetitively, like the jaw getting pushed back within the joint. When this is the normal again, and when there has been pressure put on this joint for a long period of time, either abnormally high forces on a normal joint could cause breakdown, or even normal forces on a joint that's been somehow injured or susceptible, you can get a breakdown of the outer layer of this bone. We call it degenerative joint disease. And it goes through an active phase where the surface of the bone is being eroded away. Then it can go through a healing phase, and then it can become in a more stable phase where the surface of the bone is reestablished, even though the disc is out of place. When we treat situations like this, we're trying, in the dental world, we're trying to change the pressure on the parts within the joint. And the way we do that, remember, is how the teeth fit together influences how the jaw joint parts line up. So if we can change how the teeth fit together and change the pressure on the joint, then we can allow that joint to heal more easily. This is examples of patients I saw this last couple of weeks. If we look at this side, we're looking at somebody from the front to the back. This is the skull bone, this is the brain, this is the lower jawbone, and it's round and smooth. And if we look at that joint from the side, like if you put your hands on the side of your face, we see the contours are basically round and smooth, and the socket itself is round and smooth, and this part fits approximately in the middle of the joint. That's a fairly normal looking X-ray, including CT scan. Now, if we look at this from the front, we see it doesn't have that same shape, does it? It's all chewed off the top. If we look at it from the side, it's not round and smooth. The top has been eaten away. And so how old do you think this patient is? She's 16 years old. So she has degenerative joint disease at age 16. I've seen younger than that. It's a very common problem to have degenerative joint disease, but it usually is of later age, but it can be early. We look at this image now, like from the front, it looks like a lollipop, like you just previously saw. This is looking from the side, it's round and smooth. It has the white layer on the outside. That's a perfectly normal looking joint. That's the left-hand side of this patient. Now we look at the other side, and it doesn't look the same, does it? This big dark area is a tumor in the jaw joint. The patient was not complaining of jaw problems. The patient was complaining of a tooth problem. And the patient had had root canal treatment on the tooth, and it hadn't taken care of the problem for her. And so she went back multiple times and complaining of this pain, in her jaw, but she wasn't complaining of the jaw joint issue. So when we do examinations, we want to be as thorough and complete as we can to make sure that people don't have something like that going on. This patient saw a couple of weeks ago. She's now being evaluated and treated at Mayo Clinic in Rochester, and will probably require surgical intervention, and will probably take that part out and put an artificial joint in for her. Self-care, things that you can do on your own to try to help. Number one, do not touch your teeth together. As was said earlier, people shouldn't be touching their teeth together, but if you're concentrating and you're mad or you're working hard and you're squeezing your teeth together, you're putting pressure on your teeth, and you're also putting pressure in your jaw joint. You can use moist heat. We make rice bags, just little cloth bags filled with rice, throw them in the microwave, zap them. Cold pack can be frozen peas. You can massage, use NSAIDs, avoid heavy chewing. And number one, most important thing that's helpful is try to relax, because most patients that I see are squeezing their teeth. They have muscle hyperactivity for a variety of reasons. They have tight muscles in their neck, their back, their shoulder, and their jaw. So try and relax as much as you can. Initial treatments for TMD, temporomandibular disorders, non-surgical approaches would be physical therapy, and these guys do just an excellent job with that. Exercises, medications, trigger point injections, stabilization appliance, stress management. This is a device that fits over the surface of the teeth, and we call it a stabilization appliance. And the purpose of that is to try to change how the jaw lines up. Remember, I showed you earlier that how the jaw is positioned influences how the jaw joint lines up. And if we want to change the position of the parts within the joint, the way we can do that is put something over the teeth that allows, in this case, that fits over the lower teeth. And so when the person closes together, their lower jaw will move up and make contact with the upper teeth, and it will fit into the interdigitations, the surface shapes of the lower appliance. And so this is removable, has little clips to help anchor it in place. And the purpose is to change the jaw position and change the loading on the jaw joint so that things like degenerative joint disease can in fact go through that healing process. Not all things that fit over the teeth are the same. And so there are different designs for appliances depending on what we want to try to accomplish. If we're trying to unload the joint, then we would make the appliance in one fashion. If we're trying to keep a disc from getting displaced, we might make the appliance in a different way. So if we're trying to prevent wear and tear of teeth, then we might make what's called a night guard appliance, and perhaps some of you have those. And the idea of that night guard appliance is just to protect the teeth from wear and tear that might be occurring while people are sleeping from clenching and grinding activities. But if we're trying to deal with the jaw joint, then the appliance design might be slightly differently. This is a model, a drawing, and this plastic piece here is just a mandible shape, and these are rubber bands, and it's just holding this lower jaw in that position. So it's a balance of forces. If we have somebody that is hitting only on their front teeth, and we pull on this master muscle, pulling the jaw up, flinching activities that you saw earlier, those muscle activities, we see that this lower jaw has been forced further up into the joint. There's more loading on the joint because of that direction of that pull, and it's a fulcrum. You're hitting on the front teeth. If there is full support, in this case, this is a chopstick, and it's supporting the jaw, we can still do that the same pulling on the master muscle, but the joint doesn't have as much impacted force on that. And so if we're making an appliance to fit over the teeth, and we want to, the purpose of that appliance is to change the loading of the joint, then we want to make sure that it covers as many of the teeth as possible, so the teeth are providing that support and taking some pressure off the joint. If somebody is hitting on their front teeth, for example, the front teeth are tipped back some, and their temporalis muscle, remember I showed you that earlier, how it can pull the jaw into different positions, it can position the jaw. If people are hitting too hard on their front teeth and you activate this posterior temporalis muscle to try to pull the jaw back to get away from the front teeth making contact, you can see what happens to this the mandible in this illustration. It's getting jammed back in the joint. So if it's getting jammed back in the joint, remember I said you could have a mechanical displacement of the disc in a more forward position. So in that case, we would want to make sure that the teeth fit together with the jaw in a little more forward position rather than being pushed back. So what do we do for follow-up after initial treatment? Generally, we recommend an appliance to be worn at night because people can have changes in their brain activity at night. You've seen dogs move in different ways, and people do the same thing. They have nighttime activities. If you watch people during sleep studies, you'll see they have all kinds of motions that they do. And some people clench their teeth for a portion of their sleep cycle. Some people grind their teeth for a portion of the sleep cycle, and they don't know they're doing it, and they don't have any cognitive way of trying to stop that. And so we'll oftentimes have an appliance made to support their jaw at nighttime. Possible post-treatment options, if it's needed, we may change the shape of the teeth. If the fit of the teeth was part of the original causation problem, then we might change the fit of the teeth, or we may change the positions of the teeth, or we may have to do something to the teeth themselves, change fillings or crowns or things of that nature. But not everybody needs to have that. And that in my situation, I like to get people to a position where they're comfortable and they're stable, and then we see if anything needs to be done to the teeth. Some practices, they'll change the teeth immediately to try to change the pressures on the joint, and that works great if you get it right the first time. If you don't, then you've made changes that don't need to be done, didn't need to be done, or in fact were the wrong things to do. So if we can get the symptoms resolved with physical therapy, as has been talked about, and get their jaw working better, and then they're stable and comfortable, and then we see if in fact they do have to have some dental work done. But not everybody needs to have dentistry done. I'll answer questions later.
Okay. Thanks, Dr. Booth, for that. So what I want to go over briefly here is just the associated disorders. So rarely do I have a patient that comes in that only has jaw pain. Usually these other things are associated, and we can see the images here as well as what I've written. So neck pain, there was a study by Kraus that was done that showed that 68% of the patients suffering from TMD also had neck pain. Headaches, another study in 2018 showed that 61.58% of patients with TMD have headaches. Ear complaints is something that I see quite a bit with my patients, and they can range anywhere from ringing in the ears, tinnitus, to ear fullness, to ear pain. Most of my patients, the 28 years that I've been treating these kind of patients, most of my patients arrive at physical therapy with some combination of jaw pain, headaches, and neck pain. And quite a few of them actually arrive with some kind of ear fullness or tinnitus. So this is a topic that this might be a little nerdy of me to present this, but this in my mind is the connection between the head, neck, and jaw, and why these patients have so many associated symptoms. About 20 years ago, let's say, I was at a course from one of my mentors, Earl Pettman, where I'm sitting there and he's talking about these kind of things, and he presents this topic of the trigeminal cervical nucleus. The trigeminal cervical nucleus is this part right here, part of the brainstem, where you have overlap of nerves. We call them afferents. So sensory nerves coming in from the head, from the jaw, and the neck. They're passing by very closely, and they're going off to be processed by the central nervous system. And what Earl said was, you know, this is how you basically can have your neck headache. You've heard of people before that say they've got neck pain and now they feel it in their head. So this is basically the brain becoming confused in terms of where the symptoms are coming from because of this close proximity of these nerves being processed through the brain and through the trigeminal cervical nucleus. The trigeminal nerve is one of your cranial nerves. There's other cranial nerves as well that have nuclei very close to this. So I would expand upon this, and Earl has as well, that not only can you get facilitation and crosstalk with the trigeminal nerve is pretty much a sensory nerve for the entire head, as well as it innervates your sinuses, it innervates the muscles of the jaw and some of the muscles of your ears. So you can get some of these cranial nerves, which do things like your vision and your taste and your smell, those can be affected potentially by this crosstalk within the trigeminal cervical nucleus. So what I would say is not only was presented earlier by other presenters here that you can have a muscle, say a sternocleidomastoid, that has a trigger point that you refer to the jaw or to the head because it's painful, that comes through here. But also beyond pain, you can get facilitation of those muscles. So say a neck problem that was caused from a car accident, causing neck pain and neck muscle stiffness can actually hyperfacilitate the muscles of the jaw, causing those muscles that control the TMJ, such as the masseter, such as the temporalis, the lateral pterygoids, to get tight over time and thereby lead towards some of the problems that happen. So I'm just going to postulate, and Dr. Booth presented on this earlier regarding some of the other ways this can happen with the teeth fitting poorly. Totally agree with that. I would say that some of these people actually from the neck develop hypertonicity in some of these muscles that throw off the way that the jaw is working and over time cause the problems within the jaw. I think that's also quite a possibility. Now, this can happen both ways. So I've seen plenty of patients with migraines that develop neck pain, right? So they don't really have a neck problem, but they're feeling neck pain. And the driver is really this blood flow kind of migraine issue. And I think also you can have jaw pain, maybe caused by the way the teeth are fitting together, that eventually gets sensed within the neck, causes hypertonicity within the neck muscles, and eventually causes a neck problem. So what's the natural history of how this happens? And this isn't all of them, but this is quite common. I love these pictures because it pretty much sums it up. So you can be stressed out, you can have horrible posture, and I've seen people that have posture like this. I know it looks ridiculous, but I don't know if you guys like going to airports, but I just flew to Orlando and I watch people sitting doing things all the time, and you see some of the craziest postures, and I see this kind of stuff. Obviously, car accidents, if you have trauma to the head, neck, or jaw, that can lead down the road. Like I talked about again, you have trauma to the neck, eventually facilitates some of these muscles in the jaw, and you end up with jaw issues. And obviously, this poor gal right here, did this presentation for my daughter the other night. She said that was me. She felt like this on her face and jaw, and that can cause immediate pain, obviously, in your chin that hits, but you can also have some immediate pain in the jaw. However, what I see with my patients is that they had this happen at an earlier time in life. And when I question them, I know Dr. Booth does as well, have you ever fallen and hit your jaw? And they go, yeah, you know, by the way, I did when I was like 10, and they're 50 years old sitting in front of me. But think of that trauma causing displacement of what's happening in the jaw, and maybe even changing the way the bones of the jaw grow with the growth plates not being fused, and eventually causing imbalance in the right or left TMJ that causes some of the degradation and problems that we see. So again, posture, unmanaged stress. So how does the unmanaged stress work? Like Dr. Booth was saying earlier, I mean, constantly grinding down, clenching, holding the tension in your jaw over time can cause imbalance, can potentially drive, you know, the problems within the joint that they were talking about, or even the positioning. So a lot of my patients, I'd say probably 80–90% of the ones I see have issues with unmanaged stress. So what does a specialized physical therapist do? What do Dan, Taylor, and myself do? So first of all, we do a detailed evaluation. Okay, so we're going to look at your history. I oftentimes get teased by my other physical therapists when I'm in my room for 30 minutes talking to my patient about history. But I find that the patient is the most important part of the picture. You have the ability to tell me what's been going on for you, and that can create a great setting to go on and know what to test with my objective exam. As you can see right here, we do a detailed postural assessment. We want to see how your body stacks up in standing, how it stacks up in sitting. We want to see how that head sits on the shoulder, on the neck, how the neck sits on the torso, how the torso sits on the pelvis. We do a neurological screen. I test cranial nerves. We talked about that earlier. I test smell. I test hearing. I test vision, as well as all the other cranial nerve functions. Very importantly, we do a comprehensive assessment of the joints of the TMJ. How do they move? We put our hands in the mouth. As my boss told me, wearing gloves, of course. Feeling how that jaw joint moves, as well as we're feeling those muscles intraorally to palpate them. We do the same thing with the neck. I love doing a breathing assessment. I want to see where my patients are breathing from. Do they tend to breathe up here when they're breathing? Just a guy today, I had him sit, I watched him breathing. Close your eyes. So I'm not, not weird that I'm staring at you as you're sitting there. And he was sitting there, every breath, his shoulders were coming up towards his ears. That's an inefficient way to breathe. That's going to tend to cause tension in your neck muscles and maybe lead to some of these other things. We really should be breathing at a relaxed position down here in the diaphragm. So treatment-wise, it's going to be driven by what we see in the objective exam. We're going to do manual therapy. So that's just a fancy-dancy term for having our hands on the patients and doing things to them with our hands. Mobilization, manipulation, soft tissue massage, those type of things. I spend a lot of time in the postural reeducation realm. It's not easy to change posture, but it is possible. I find it's easier with the younger population for a couple of reasons. They're more flexible than the older population. Sometimes we get mechanically stuck here, and to get somebody really fully upright and into a perfect posture is pretty difficult. I haven't met a patient that I could never change their posture just a little bit. And I would tell my patients that sometimes that little bit makes all the difference. Very importantly, we talk about behavioral changes. So we've talked a few times about stress. We've talked about posture. We talk about things that we're doing in terms of computer use. I spend a lot of time talking to my patients about how we can change these things. How can we work on your stress? Tell me a little bit about your stress. Where is it coming from? Is stress something that's coming from X, Y, or Z in your life? Can we change those things? Not a psychologist, but I think sometimes just thinking through those things can be helpful, and getting the patients to understand that stress, psychological stress, is creating a biomechanical musculoskeletal problem in these patients. Other behavioral things are, again, breathing, sleeping. So we go pretty deep with our patients. Again, breathing re-education, teaching patients to breathe down here in the diaphragm and maybe not so much here. And then very important self-help exercises, which we're going to go over a few here in a second. And here we are. I would love to sleep like that. I don't sleep like a baby, unfortunately. Just a show of hands, how many people here feel like they have trouble with sleep, either in terms of getting quality sleep or enough sleep? Because I'll raise my hand right away, okay? So I would say, and this comes from many sources, the very best thing you can do for yourself from a health perspective is learn how to sleep better and really work towards sleeping better. Because what does sleep do for you? It basically cleanses and replenishes your central nervous system overnight, okay? And if we have these people that are stressed out and they can't cope with what's coming at them daily with life, having less sleep in your life and not being able to replenish your central nervous system is going to make your stress a lot higher. As well as it affects really almost all parts of your physiology and your health. So I spend a lot of time with what I call sleep hygiene. I talk to my patients like, okay, you brush your teeth, right? Let's talk about brushing your teeth hygiene or tooth hygiene. Why wouldn't we think about those things we can do in our life to make our sleep better? And these are just a couple of things. This is hard again, right? But can we get, the research really shows for adults about 7.5 hours of sleep is really what's needed to get good replenishing sleep. It's higher for younger people. But this is tough for me. I get exactly 7.5 hours of sleep because I've trained myself from 5.5 hours to 7.5 hours through some of these things we're going to talk about. And one of them is the regularity of your sleep window. Okay. So if you're one of these people that has a job where you work different hours every week, really, really bad for your sleep because your brain never really knows when it's time to sleep. You have to train your brain on a daily basis on when to go to bed and wake up. And if we're saying generally we go to bed about 10:30 every night, and generally we're getting up every morning about 6 in the morning, 6:30, something like that, our brain will actually wake us up generally at the same time because it knows it's time to get up. I had a patient the other day who's a police officer, and she has this schedule that changes like almost every other day. And she was literally yawning the whole time she was talking to me, and big circles around her eyes. And I said, can we talk about this? Can we really discuss your sleep? And it came down to that she can't change her job right now, but she's going to very soon. And I said, great. You need to get your brain comfortable with when it's time to go to bed and when it's time to get up. So that's just one. These are just a couple of things we talk about with the amount of time and the regularity. There's other things that I don't have time to go into, but it can be complicated. And sometimes I get real resistance from my patients. They're like, no, you don't understand. I'm a really bad sleeper. I say, I get that, but can we do just a couple little things to change this? And it's really amazing sometimes how they can change. So under the self-help tips, we're going to go through a quick little exercise here with massaging the temporalis and mandible, or temporalis and masseter. I'm going to hand out some gloves for anybody that wants to try this in kind of just one hand, right or left hand dominant. So they'll pass those out for anybody that wants one. I'm going to show you how to put your hand in your mouth and massage your masseter. So masseter is probably, or it's definitely the number one muscle that I show patients how to massage. Like if you were on an island and you only had a couple exercises, I don't know if you remember some old sci-fi movie, Time Machine or something, like what book would you take with you to an island if you only had a couple of books? If I only had one exercise or a couple of exercises, this would be one of them, because so many people hold tension within their masseter muscles. And then I'm going to have Dan come up here and I'm going to show him, or Dan or Taylor. Can I massage your masseter if you sit right there? Okay. So you want to use your opposite hand. Whatever hand you put your glove on, you're going to come across to get the other side. So I'm going to be Taylor's hand, his right hand, to massage the left side. So he's going to gently turn his head this way. Go ahead and open your mouth. Guys, go ahead and do this as we're doing it. So you're going to insert your thumb on the opposite side outside your teeth. Now you can close your mouth so that your teeth can be slightly apart, but you don't need to keep your mouth open for this. Now, very interestingly, my thumb, if I'm not very far back, is going to feel a lot of cheek. And some people sit really far back with their masseter, and this guy is one of them. So I have to really go back far this way, and you might have to do this towards your ear to get the masseter. Okay, so now I have my thumb on the inside, my fingers on the outside, and I'm going to have Taylor, and you guys can do this too. Go ahead and just gently clench your jaw. And you should feel that muscle suck your thumb into your teeth, and you should be able to feel it between your thumb and your fingers. Okay. So now that you're there, you're going to use both the thumb and the fingers to massage this muscle. You're going to start up high. You're going to push the thumb in that direction to put a bowstring in the muscle because the fibers run this way. And you're going to use your thumb and your fingers to massage top to bottom, all the way down to the lower angle of the jaw. And then you're going to release, come back up, put pressure, go top to bottom. So you can see here, I'm moving through my wrist. Okay. You guys are all doing great. I can see good technique out there. You want to go come across to the other side though. Yes, there you go. So that's the master. I'm gonna have, you can go ahead and take your glove off and just toss it on the ground backwards and we'll pick it up for you. Temporalis invades is in this whole area. It's a thin muscle, but it's a very big surface area. Okay, so it's this whole area here. I talk about this muscle being like two small pancakes that we put on either side of the head. If you look at a skull has a little indentation in this temporal, we'll call it the temporal fossa. That's where it sits. So take 3 fingers of either hand. You're going to come above your cheekbones, behind the eye sockets, and you're going to start right there. Okay. And so with those fingers now, you're going to move your skin on top of the muscle to do small circular motions. Okay. Most people love this a lot more than the master because it's just kind of relaxing. Okay. And so we're going to think about doing laps around the temporalis. So we're going to do these little circles within the greater circular area of the muscle. Now I'm going to move my fingers and I'm going to grab this skin just so you can do the same. You're going to do the temporal massage. Jackie, you probably want to take your glasses off. And we're going to do a circular massage as we come all the way around and really move around that muscle. And typically I have patients do 6 laps. Okay, I'm coming in for 1 lap. It's nice to do both sides at once. And then I repeat that 6 times. This was shown initially by Mariano Roccabato, kind of like the god of physical therapy, treating this stuff. He's been around forever and he lives in Chile, right, Jim? And he calls it the Roccabato 6x6. I can't get many patients to do this 6 times a day. So I'm changing it to the David Coletta 3x6. I'd sometimes, if I find a patient that really needs it 6 times a day, I will tell them 6, but usually it's for me just being reasonable 3 to 4 times a day. So both the master, 6 strokes either side, 3 times a day, and the temporalis, 6 laps around 3 times a day. Thank you. Okay, lastly, really love this picture. Look closely at this. So this is a client of mine who I asked his mom and him if I could use this picture as long as I blacked out his face. But look at that initial posture. I think the screen is actually making the posture even more bend, but look at the posture on the top versus the posture on the bottom, okay? Initially, just aesthetically, that looks way better, right? And I try to make this claim to my patients, and it works on a lot of younger people, like, this just doesn't look good. You know, you don't look confident. You don't look like you're ready to go. You look like you're kind of a slouch, right? And when I do this with my patients, I do this with quite a few. I ask permission first, but this is for their file. I say, can I just take a picture of you in side view? Don't give me anything special, just stand there. And this is what he gave me on his first visit. Okay, picture. On his last visit, again, I said, go ahead and stand there for me. Don't give me anything special. And this is what he gave me on his last visit. This, I believe, is 6 or 7 visits later over about a 6-week period after giving him exercises, behavioral exercises, stretches, things to work on, but as well as changing what he did. Now, this individual was a gamer. Like, how many hours a day do you do this gaming? 6 hours a day. What does that look like? It looks like this. You know, so he's sitting here like this all day long doing a behavior. So we worked on getting him into a position where he can game in a more neutral head position over torso, over pelvis. And then we talked to him about moving a lot, right? So can you please get up and move and go back to this position? Just don't hang out here for 6 hours. Ultimately, it'd be great if he wasn't gaming for 6 hours a day, but you know, this kid loved to do it. So when I talk about posture, a lot of times I talk about stacking, right? So stacking the head over the torso, over the pelvis is in a good vertical line. You should be able to stack these things. What you see, and you see on this top picture, is this guy has his head forward, not stacked over his torso. His torso is back, and certainly not over his pelvis. Why do we care? We care because that puts a lot of pressure right here, and it puts a lot of pressure on the jaw. And Dr. Booth talked earlier about that mandible kind of getting pushed back in the condyle of the joint. I think sometimes that happens because of that forward head position. All of you, when you were touching your teeth and you were going into the forward head position, most of you were biting back further, meaning this bone was sitting back further. So that's another way that can happen over time. Again, I love to get people young because we can make lots of great changes. I mean, this guy didn't have a stiff thoracic spine. This posture was in his brain and in his behavior, and it had changed the way his body, and by the way, his symptoms were severe headaches, severe jaw pain, severe neck pain, and I think he was like 95% resolved within that short amount of time, okay? And I really believe it was mostly about that posture. So a quick little activity. I want you guys to put your thinking caps on, and I want you to think about having an eye hook drilled into the top of your head, okay? So that eye hook is drilled into the top of your head center, but back about 1 inch, okay? So can we all visualize that? I want your feet flat on the ground. You got that eye hook, and that eye hook has a little hole on top. Now I'm going to tie a rope to the top of that hole, and there's going to be a rope going all the way to that really high ceiling on a pulley, okay? And now that same rope is going to go to a pulley right above me. And now I've got a rope, and I'm attached to the top of your head, okay? And now I pull down, and I'm going to get to the point now where I pull any further, it's going to move you. So I want you guys all to mime for me, now that you're sitting there and that's attached to your head, as I pull, what's going to happen to you, okay? I want you to do it. Okay, so what it's going to do is it's going to lengthen your spine and almost in sitting, feel like your sit bones, your butt bones are going to be lifted up into the air. So that lengthening will naturally pull your head back over your shoulders, will naturally pull your torso into position, will naturally drop your shoulders down, as opposed to what I see with a lot of my patients is I say, okay, what do you do to find a better posture? And they go, I go like, I go like this, right? Which you can't maintain because it's a lot of work on the backside to do that. So just a little demonstration how you can improve your posture, which also can be done in standing. Same thing, you know, as I pull on this, eventually it's like your heels almost want to lift up because you're being lifted. And because it's not dead center and it's off back a little bit, it does drop your chin a little bit and then pull you up. So instead of this, we have this. With that, I want to open it up to questions. So I'd like you guys to come up here, and Dr. Booth as well, and take a seat so you guys can ask us questions. Do you guys have any questions? There are no bad questions, by the way. So just raise your hand if you have a question. Yes, back row. Uh-huh. Uh-huh.
But now I'm like wondering if you would continue to posture next.
So we're recording this. So the recording can hear what you said. Jackie asked, she said her husband has ringing in his ears. She doesn't understand the connection on how ringing in the ears can be connected to anything about what we're talking about tonight. How's it connected? So it doesn't have to be connected. So there's different reasons you can have ringing in your ears, right? There's some serious reasons why that might happen. Brain tumors could be one of them. Just don't want to worry you, but very, very rare. More often you go to the ENT or the neurologist and they do all this checking. They come away and they say, I don't see anything, right? There's nothing wrong with your ears. There's nothing wrong with your brain. We're going to give you idiopathic tinnitus, okay? Meaning big fancy word with I don't know. And then to his credit, I work a lot with Dr. Dodson here in town, and he's an ENT that sends me quite a few patients. And he's like, I don't know what this guy does with my patients, but they seem to get better generally with these ear things. When I can't find any ear problems, they come to see me, and we can work on posture, we can work on neck, we can work on jaw, and a lot of times improve that tinnitus, sometimes make it go away. But the connection is, in my mind, neurological. It's that trigeminal cervical nucleus that I showed you earlier, whereby you can get facilitations of muscles in your inner ear, right? So tensor tympani is a muscle in particular that attaches to your eardrum. That's a trigeminally mediated muscle by the trigeminal nerve. So if we go to the trigeminal cervical nucleus, you've got a neck problem that's giving information into the trigeminal nerve through the trigeminal cervical nucleus from the neck. You can hyperfacilitate the tensor tympani, and the tensor tympani can change the way that things happen in your ear to get like fullness or tinnitus. Does that answer your question? Oh, sorry. Other questions?
From a dental standpoint, in the jaw joint, there are capsular ligaments that hold everything together, just like there are ligaments around your knee. And embryologically, when the jaw develops, the fetus is growing, and there's a thing called Meckel's cartilage. And Meckel's cartilage divides into 5 parts. One of the parts is the ear bones. One of the parts, there's 3 of those, and the other 4th one is the mandible. So the mandible, the lower jaw, is related embryologically to the ear bones, and the 5th part disappears. In some people, there's a fissure in the bones that through that fissure, there is a ligament that goes from the capsule of the disc of the joint. Saw illustrations of the disc. And that ligament goes to the malleus ear bone. It's called Pinto's ligament. And about 30% of the population have that ligament that you can find on cadaver dissections. So for some people, when they have a jaw joint disturbance, that can change how that malleus ear bone functions by way of the pentose ligament. Discomallear ligament is the other name for that. So sometimes we do see ear symptoms change when there are internal jaw joint problems, disc displacement issues, but not always. And many cases of tinnitus are unknown why it happens. And it's very frustrating for people because they want to know why it happens. And sometimes we have reasons for it, and sometimes we don't.
Other questions? Yes, yeah.
What do you think about?
So the muscles of the TMJ, you mean? So Botox is a injection into a muscle to basically deaden the muscle so it's not having that activity that may be painful. I think sometimes it can be good for some patients. So a lot of different providers nowadays, by the way, for this recording, Anne asked, what do you think about Botox for some of these patients that are having problems? So it's not being injected into the joint, it's being injected into the muscles, the masseter, the upper cervical muscles, the temporalis, those kind of things, to decrease that activity within the muscle and thereby relieve symptoms. And it does relieve symptoms for some patients. My perspective is I want to get down to the brass tacks of why this muscle is an issue in the first place. So it's not like I'm against it. I just want to make sure those patients are not just going back in for Botox and then it wears off in several months and they're coming back in for Botox again. Yeah. Do you have any experience with your patients getting it, or you just heard?
Was excellent, and she said it's not indicated. She was not.
Oh, interesting. I think it works. Again, I want to get down to the issues of what's going on and causing some of those muscular problems in the first place. Jim, do you have an opinion on that?
I do. Like David, I would rather try to figure out what's causing those muscles to become hyperactive in the first place. Figure out the cause rather than trying to paralyze them. I do have patients come in that have had Botox and in jaw muscles. And I haven't seen any that have had great results, but I don't see the people that have great results. I see the people who have problems that weren't helped with it. There are some side effects from Botox. You can have a degeneration where the muscle just quits working, and you can have some undesirable facial contour changes associated with that. American Academy of Oral Facial Pain, which I'm a fellow of and have been a member for many years, that was great discussions about that this year at the annual meeting. And consensus was they weren't so favorable towards it. Patients do come in requesting it or have had it in a variety of places. I don't generally recommend.
Other questions? All right. Well, thanks. Yes. Thanks so much for coming. I know it's, went a little longer than I wanted to. My associate Jason told me that people couldn't handle more than 45 minutes, and you guys did an hour and 15 minutes. So thank you. And thanks. We're here if you want to ask them some more questions. Oh, yeah.
So do you think the starting point to see a dentist or the starting point is to try physical therapy?
So the question is, where do you start if you have an issue? Do you start with the dentist? Do you start with the physical therapist? First, I would say start with a specialty dentist or a specialty physical therapist. I think you're going to get further with them. And for me, I mean, with Dr. Booth and I working together, we pass patients back and forth all the time. I think it really depends on what's going on with that patient. If the patient's having a lot of locking, serious jaw joint issues, might be better to start with Dr. Booth than me. If it's more just kind of they're dealing with some pain, it hasn't been around as long, they're not locking as much, maybe with me, but I think really you could do either. Do you have a perspective on that, Jim?
Some people only have a jaw joint problem, and some people have a neck problem, and some people have neck problems and jaw joint problems that are independent of each other, but commonly they do overlap. And so if it's only a jaw joint, problem, popping, clicking, locking, soreness in the joints, then I would say that you might be better off going through the dental approach. And most dentists, all dentists have had some training on temporomandibular joint disorders. And so you could check with your general dentist first. But there are different approaches on how to deal with TMJ problems from a dental perspective. So you can certainly check with your existing dentist first. If they feel comfortable in treating you and you feel comfortable with them providing treatment for you, great. If it's beyond what your dentist wants to do, then they could see a dentist who deals with TMJ problems all the time.
Yeah, I think that was well said.
To kind of follow that up as well, if you're gonna like to go to see like a physical therapist first, while a lot of physical therapists have a baseline education, maybe in the temporomandibular joint, I would say a very small percentage of that then actually feel comfortable treating it. So if people opt to go PT first, just making sure that it is somebody who knows their stuff.
Okay, yes,
I've been to the general dentist,
yes,
so I have a lot of patients that come in. I always try to talk to them and figure out if there was some sort of an incident. Often that is more short term and you can just try to teach them how to relax the muscles. I then usually start with some sort of a night guard appliance, depending on if it doesn't seem like a specific joint problem. And then there's different appliances. If it gets hard, if they're not responding, or if they have more complex, I refer to these two. So, I think most people probably do that, but it depends on what your situation is. Really, you need to talk to someone about it. Is this an acute situation? Did you fall and hit your head or whiplash? I go straight to the physical therapist. You know, if it's a week before the wedding and she's absent all the time, I may get a night guard. So it varies a lot.
and we do get a lot of referrals from general dentists that have the exact same approach that you're talking about. And I do think that's a good stop for a patient because most dentists are going to have some familiarity with this. I'm hurting here. What's going on? They're going to their dentist to kind of figure it out. So thanks for that perspective. Yes.
Experience with insurance coverage.
Mm, great question. So the question is, what's the experience with or what's my experience, or maybe Dr. Booth's experience with dental insurance? It really depends on what's going on with the patient in terms of what's driving their problem. There are many health insurances that won't cover TMJ dysfunction, probably from a dental as well as a PT perspective. So that code that you put on the patient's case that says, this is what's going on diagnostically will drive that possible denial. So with my patients, if I have a patient that really is driven mostly by muscle, mostly by posture, mostly by neck stuff, I'm going to keep that off. If it's a very joint driven issue, I can't ethically keep it off. I need to put it on. And in those patients, I'm telling them ahead of time, this is something that your insurance is going to deny. I don't treat you many visits, but I can help you a lot. We can do self-pay, which is a little lower, rate than the insurance. But the majority of my patients, we do insurance and we're able to go through insurance, majority, but there are some that can't. Jim, what do you?
People have medical insurance and people have dental insurance. And within those insurance policies, each policy has different things that it covers and things that it doesn't cover. And so most insurance policies do not cover TMJ problems, TMD problems. And it seems crazy because if you had an elbow problem, that should be covered. If you had a knee problem, then that would be covered under your health insurance. If you have a jaw joint problem, the insurance company doesn't know what to do with it, and they typically deny.
So
I'm sorry.
Someone wants to do this and check all these things out because it's the open season, and there is one that does it emeritus,
Mm.
and they do they'll also have a bunch of implants and things like that too.
It just depends on how your policy is written and what you are buying or your employer is buying.
I'll mirror what Jim is saying here. It's absolutely crazy that it's not covered by medical insurance because it's very treatable. It's a very real problem. It's not in their head. And I don't know the history. When I came out 28 years ago, they were already denying it. I don't know if there was maybe a proliferation when it became very fanciful to treat TMJ. And so they said, oh my goodness, we can't treat all these patients. We're just going to deny it all. Perhaps that's what happened, but it really is crazy that it's not covered by a lot of insurances. Yeah. Great questions. Any other questions? Awesome. Thanks so much for coming. Appreciate it.